Good morning, everybody. My name is Peter Lewin. I'm from Drexel University in Philadelphia, and I'm here to introduce our plenary speaker. First of all, I wanted to thank the organizers for giving me this great honor. It's truly a great pleasure to introduce Professor Konafagou, who rose to prominence at Columbia University here in New York. She's Robert and Margaret Hariri Professor of Biomedical Engineering. She's also Professor of Radiology. And instead of reading her CV, let me say a few words about Elisa. First of all, she's authority in biomedical ultrasonics. She's one of the visionary scholars and leaders transforming the landscape of healthcare. She designs and develops ultrasound-based technologies with the ultimate goal of improving the quality of life. And in fact, these accomplishments can be nicely illustrated by these statistics. According to the National Institute of Health, only a tiny fraction of investigators holds more than 5 concurrent NIH awards. Elisa currently holds 7. Now, this, of course, is being used to support her research team, which comprises of 16 PhD students, 7 postdoctoral fellows, 2 research associate scientists, 1 assistant professor, and several masters. What are we working on? Well, first of all, harnessing Alzheimer's. And this is being done by opening the blood-brain barrier and delivering drugs directly to the selected volume of brain tissue. The other project which Elisa and her team are working on has to do with pulse wave imaging, which has ability to predict the likelihood of stroke. And the third one is electromechanical wave imaging, which I'm pretty sure Elisa will elaborate on. Elisa is an inspiring and engaging speaker, and I look forward to her talk, which will unveil the incredible effectiveness of ultrasound.
Hello, my name is Elisa Konafagou, and today I'll be talking to you about imaging cardiovascular mechanics for disease diagnosis. So arterial disease has different aspects, and all of them are silent killers. So some of them are listed here, such as coronary artery disease that leads to myocardial infarction, which is the leading cause of death in the US. Carotid artery disease that leads to stroke, which is currently the 3rd leading cause of death in the US. Abdominal aortic aneurysm and hypertension. So for the purpose of this talk, I'll be talking about mainly carotid artery disease and concentrating on the carotid, which is basically lining all our necks and furnishing blood supply to the brain. So what is carotid artery disease? It's a narrowing of the lumen of the carotid arteries, as you can see here, a progressive disease that leads to occlusion of the blood flow to the brain, and as a result, plaque rupture stroke may occur. The major treatment is through cardiac endarterectomy, which is basically a removal of the plaque, and or carotid artery stenting. So for the criteria for that is the degree of stenosis and symptomatology. So whether how large is the actual degree and what are the symptoms of the patient. And of course, sometimes that has limitations because low stenotic plaques can also rupture, and that can have a limited information on the early stages of atherosclerosis. So for the endarterectomy, they're looking into making a small incision at the area of the plaque and then being able to aspire the plaque and then sealing back the actual artery. So for that, the indications will be to have a stenosis with symptoms exceeding 50% or without symptoms exceeding 60%. So it has been shown that endarterectomy is beneficial, especially for symptomatic with high degree of stenosis. And but there may be some residual recurrent stenosis after endarterectomy that ranges from 12 to 20%. And the idea is to have an imaging of the arterial wall local mechanical properties to inform the success rate of potential endarterectomy. So what can biomechanics or mechanics of the arterial segment do as a result of informing both diagnosis and treatment? So there is a loop between arterial stiffness and atherosclerosis that's well known, that if arteries start stiffening, then they become a very fertile bed for atherosclerosis. And when atherosclerosis starts forming, then that stiffens the artery. And that's very important for both looking at the cause of stenosis, but also looking at progression of disease. So it's very important to accurately inform on plaque stiffness and looking at specifically for softer components that have been linked to vulnerable plaques. And vulnerable plaques has an indication of several different biomarkers, such as inflammatory cells or thrombus forming on a very thin fibrous cap that cannot sustain the pressure of the formation of this abnormal structure that is indenting the lumen. And of course, what we're here for is to actually be able to look at and predict cerebrovascular dysfunction, and stiffer carotid arteries have been associated with that. But currently, there's no way of actually informing on the clinical side whether an artery is stiff or not, other than just looking at the stenosis level, which has nothing to do, of course, with the stiffness. Another aspect that we also want to be able to measure in vivo is the hemodynamics. So one thing is the plaque itself and the wall mechanics, but also the hemodynamics are leading to the formation of the plaques. So we know a lot about the hemodynamics from duplex ultrasound that looks at both the actual structure of the anatomy of the vessel, but also the underlying velocities, as well as MRI that has, with phase contrast, can do four-dimensional blood flow imaging, but is more restricted by spatial and temporal resolution as well as cost. So why do we want to look at the patterns other than just looking at the blood flow velocity? And very important aspect for has been linked both to correlation of disease progression, but also causation potentially, is the wall shear stress. So that's the stress that is building up as a result of the stenosis. So there's acceleration because of the changes in the Reynolds number, and then that leads to high or low wall shear stress, and the changes of that could actually erode the plaque that has been forming and leads to a higher risk of cerebrovascular disease. So this is one of the holy grails of atherosclerosis, how we can measure another biomarker of wall shear stress in vivo. So what we're currently focusing on with that technology of pulse wave imaging that I'm going to introduce in a second is on the arterial pulse wave. So we can all feel our pulse by holding on our fingertips against our carotid. That allows us to measure, for example, our heart rate. But it also contains information on the underlying stiffness. So this is a schematic that shows how the aortic arch here is emanating from the actual heart and then feeding blood supply to the rest of the body. Of course, we're looking at the carotid, which is in blue here. But what you can see here, both in the carotids and the aorta, you have a change in the pressure, and that leads to a wave that at different times will lead to a distension. And one of the greatest biomechanists that has worked on everything from arterial biomechanics all the way to cartilage is Y.C. Fung. And he has stated a few years back that if we were able to read all the messages of the arterial pulse waves, then all we need for non-invasive diagnosis is to observe these waves in some conveniently located arteries. And if the messages are clear and unequivocal, then the art of non-invasive diagnosis would have been moved ahead a big step. So leading through that, we also borrow from what has been known for a couple of centuries now, is the pulse wave velocity that can inform of the mechanical properties of a tube, such as the vessel, and it has been linked to an independent marker of cardiovascular disease through the link between arterial stiffness and pulse wave velocity. and more specifically, the Young's modulus to the Mohs water-going equation, and to the compliance through the Bramwell-Hill equation. So overall objectives for our technology is to develop and clinically implement an imaging-based method for visualization and assessment of the arterial pulse wave, then identify both qualitative and quantitative pulse wave features that may aid in the diagnosis, characterization, and treatment of the arterial disease, and then in general generate new insights into what the arterial wall dynamics can teach us about pathological conditions and potentially prediction of stroke. So first thing, how can we actually measure this in vivo? And we have developed over the years this technique called pulse wave imaging, which allows us to image and map the pulse wave. Some areas, so this falls under the umbrella of ultrasound elasticity imaging. So it means imaging of elastic properties of tissues using ultrasound. There's typically a mechanical force, external or internal, that leads to a tissue deformation, that then leads to a tissue motion. And the way that we actually measure motion in ultrasound is by tracking this underlying coherent scattering called speckle between the successive ultrasound frames. And then we can actually reveal elastic properties of the soft tissue. So obviously pulse wave imaging falls under this umbrella, is a non-invasive method because it uses ultrasound, and it looks at the intrinsic deformation of the vessel at every pulse propagation, and it's used to visualize and map that propagation throughout the entire wall that's being imaged. And in order to do that, because these velocities I'm going to show you in a second is on the order of meters per second, we have to use very high frame rates on the order of thousands of frames per second, which is afforded now by using this high speed of sound that's on the order of course, 1.5 meters per second, that allows us to do very fast frame rate imaging by programming the beamformer or the way we send the waves through conventional scanners. We have direct access to large central arteries, such as the carotid, through ultrasound imaging. And this can be, as a result, a very highly translational technique that provides low-cost, portable, fast, and non-ionizing radiation. So this is a schematic of that. So obviously the heart, at each heartbeat, is pulsing, and then sending this wave, propagating along this tube, which informs both the flow and the propagating along the actual wall. So what you see here are the two walls of the carotid. The top wall is having the pulse wave propagate in red, so that means motion upwards towards the transducer, which is always on top in the ultrasound images. And then blue is away from the transducer. That the red and blue means that the actual artery is distending, allowing the flow that you see here in orange going from the heart to the brain, which is on the right. So as I said, you can use the Mohs water-going equation, which is not as general as the Bramwell-Hill equation that I'm going to be focusing on, that leads the compliance of the change in area over the change in pressure, and then linking that to the pulse wave velocity that you see here in the denominator. And the advantage of using the Bramwell-Hill equation is that you no longer have to assume a thin wall or homogeneity in that tube, as you actually do with pulse wave velocity when you use the Mohs water equation, and you can actually have something closer to what happens in the carotid artery in vivo. So as I said previously, we use standard ultrasound transducers as the one you see here that send these waves, but we actually have different types of beamforming. So we send the waves at different times, and this is one way of seeing how these waves arrive at different times using 3 different wavefronts that are almost in parallel with the actual transducer here. We have some ultrasound scanners that can go up to 8,000 frames a second. We use what's called plane waves, so we don't focus and transmit, only and receive, and this affords us a very fast frame rate that then allows us to, as I showed earlier, be able to have both the anatomical information on the walls, but also the functional information. and be able to have the motion estimation that allows us to have minute motion on the order of microns on both the walls, and then allowed to generate spatial temporal maps that have both on the top wall that undergoes a positive or towards the transducer motion, and the bottom wall, which is basically allowing us to have the motion away from the transducer or negative motion. And that's after wall segmentation and looking at both the proximal and distal walls. So for measuring the pulsewave velocity, that's of course the slope of that spatial temporal plot. And here is what we see typically, which is about 4 meters per second in a normal artery. And we also have this linear regression that allows us to see also the uniformity of that propagation with an R-squared or correlation coefficient here, very uniform, a textbook type of correlation of 0.97. So this is great for a normal artery, and we can see how it's very nice homogeneously distending. But of course, in order to see a local variation in that homogeneity and overall normal function of the artery, we have to do piecewise linear regression. We call this piecewise pulsewave velocities, in order to be able to see any homogeneities and also identify any stiffening or changing in the stiffness. And here, for example, of course, a normal artery is very uniform propagation. There's some changes, but overall, as I said, on the order of an average of 4 meters per second and very high correlation coefficients that also allow us, because we have very small, these kernels are very small on the order of millimeters, get a map of the compliance. And you can see here, for example, we can map in vivo the compliance map, how it changes across the entire wall, in this case, the anterior wall of the carotid artery. We can see that this is about a factor of 10 in the compliance. And then with the Brabham-Hill model, we can actually have an average compliance for a normal artery. So that's one way that we can inform the mechanical property. Another way to see whether we have any inhomogeneities, even at the early levels where you don't have any stenosis, just changes in the mechanical properties, we can actually convolve the velocity of the wall variation with subsequent velocities in other frames. We have this marker one, which is basically the area under the curve after convolution between these two curves of the velocity. And then we have a second marker that's the more typical one that looks at the 50% upstroke. That's basically 50% of the max of the velocity of the wall. And then also looking at the acceleration of that by taking the gradient of the velocity. So these two markers allow us to see how this changes across the entire wall, and we call those homogeneity markers. So when we look at specific phantoms, which are basically allowing us to evaluate the technique prior to using in vivo in patients, we have made what's called a stiff-soft interface. So this is a transition between two different regions of a tube that goes from soft to stiff. And we can see here that with such a compliance and homogeneity measurement, we're able to actually very nicely identify the interface with a transition of about 0.5 millimeters, and properly look at both the soft segment and stiff segment by identifying the drop in the compliance, both with a static testing, a mechanical testing that allows distension, and looking at the pressure versus the rise of the height of the fluid. So very standard, and we're able to actually match that also with our measurement from between statics testing and our pulse wave imaging measurements. So a correlation with preliminary mechanical testing in phantoms. And then a couple of things before I get to our measurements in patients. We can also do this in 3 dimensions. Similar beamforming that we can do in 1 dimension or that leads to 2-dimensional imaging in ultrasound. We can also have matrix arrays. So this is basically the arrangement in 2D of the elements and able to send now waves in 3 dimensions which allows us to get three-dimensional structure, in this case of a vessel, and then being able to see motion estimation and propagation in all three dimensions, and then through segmentation allowed to overlay the motion onto the segmented vessel. And then when this happens, we're able to track the wave in 3 dimensions and measure all 3 components of the velocity on the wall. In this case, I'm showing you on the bottom, this standard velocity that we have in the longitudinal direction, where we have the wave propagating, and we can see the wavefront, and then make the actual spatial temporal plot now with the forward wave and the reflected wave clearly seen and resolved because of the actual temporal resolution. And then, of course, we can do now surface mapping and fitting that allows us to get all the components, especially in the y direction, but also the x direction, and identify how the actual wave propagates in both the longitudinal and also circumferential direction. And this is in 3 different normal vessels, where we find that the plane fit was in the order of 0.88 for correlation coefficient, and the longitudinal direction averaged about 5.8 meters per second. And then this is a common carotid in one of the 3 normals that we mentioned, that allows us to see the propagation of the wave, and then after cross-section, both in circumferential and the longitudinal direction. Following this wavefront here, you can see in the top 3 frames of the previous 3-dimensional movies showing the propagation of the wavefronts on the surface and also on the cross-section. And when we do that, we're able to actually see that there's very nice correlation between subjects in 3 dimension with both the 4-dimensional PWI, but also the 3-dimensional, 2-dimensional in time for all 3 subjects here, but also in subsequent subjects, where again, the average for the pulse wave velocity in 3 dimensions was on the order of 4.8 meters per second. So of course, so far we mentioned mainly the wall compliance and what happens with the pulse wave velocity propagating along the wall. But there's another part of this equation, that's the flow, that's also as driving the pulse wave, but also can be, as we're going to see, disturbed in the case of stenosis. So we can measure both the flow and the pulse wave velocity at the same time. I don't have time to go through all these Doppler velocities and vector Doppler velocity that we're able to measure. But in a nutshell, you can see here this video that's playing that we can actually cross-correlate within the flow, the lumen itself. So follow these velocities here, and I get in a minute to the magnitude of that. And at the same time, find the timing of this wave propagation. So you can see the red wave and the blue wave propagating along the 2 walls, while also the flow propagates. So this has allowed us to actually do this dual imaging of both looking at the compliance and the velocity at the same time, and then mapping those together. So when we do that in a couple of common carotids, you can see here 2 subjects, normal subjects, we're able to get that simultaneously. And this has allowed us to actually look at the pulse wave velocity at the same time as the peak distension wall velocity and the peak flow velocity. And we can see very different magnitudes. Of course, as we mentioned before, pulse wave velocity on the order of about 5 meters per second, peak distension wall velocity, so that's the peak distension that you see on the wall, on the order of 7 millimeters per second, while the peak flow is on the order of 60 centimeters per second. And when we look at the correlation between peak flow velocities, peak axial wall velocities, there's a decent correlation, negative correlation, negative slope, I'm sorry, and pretty decent correlation in the 2 subjects here. Another very interesting aspect that we're going to put in practice for wall shear stress is actually what we found, that we can measure the streamlines now of this flow at the same time as the pulse wave velocity. And this has allowed us to look at the flow as it changes during the cardiac cycle and its impact on the wall. So as soon as these streamlines are touching on the wall, we can actually see the impact and potentially something that we want to look at further, the progression of disease as this flow, as it changes over time, is affecting the overall wall deformation. And these are some of the streamlines that you can see at different time points during propagation. So we can barely see in the beginning the wall distension, but then it becomes very apparent as the pulse wave propagates. Again, there are two waves, red wave on top, blue wave at the bottom, and we can see the accentuation of some of the streamlines. And then there is these flow vectors that align with the vasocenter line and peak systole that we can follow this angle difference over time as the pulse wave also propagates. And that's normal flow. This is another way of visualizing that by having this virtual markers that we can overlay on top of the actual lumen and force those to undergo the measured flow velocity pattern that aids the visualization of the flow. And then, of course, we can see with the streamlines in a normal carotid. So that is where the carotid at the neck bifurcates to the external and the internal. The internal is on top, external is at the bottom. And we can see that the external one is actually having a natural vortex that is building up as a result. And that's actually known. We can visualize that. So we have a vortex that's building at that part of the carotid, the bifurcation, and that allows us to see the overall effect in a normal vessel. Another aspect of that is what happens to the internal carotid, and you can see another formation here of this very interesting streamline. That if we can zoom to that, we can see that if we actually do have we map the actual peak velocity of the wall and the streamline here, we can see that the two overlap very nicely. In fact, this particular site has been linked with the formation of atherosclerotic disease. So we're very intrigued by that. At the bifurcation, a lot of the sites of early onset of atherosclerosis in the carotid start here. And we may have some insight by looking at both the fluid dynamics and the interaction with the wall dynamic, with the wall mechanics. We can probably inform the onset of the disease formation. So very similar to what we did also with the pulse wave velocity, we can also map that flow also at the same time as the pulse wave velocity in 3D. Okay, so we also wanted to look at that in simulations, and for the longest time it has been very difficult to map both the fluid dynamics and the solid mechanics and the interaction between these two. And we were able to do this recently by partnering with the biomechanics group headed by Gerard Ateshan in mechanical engineering at Columbia, and then being able to use FE-Bio that Gerard has actually developed with other collaborators of his. So what we were able to do is basically simulate an artery with a plaque. So we know that the Brown-Wall-Hill equation is something that we have applied in the past, and this is again the equation here. And we wanted to separate geometry from mechanics. That's something obviously that you cannot do in vivo, but we're of course able to do in simulations. So we had very similar interesting findings, as I'm going to show you in a second, that we have at the side of a plaque, we have a transmission, but also reflection as a result of the change in the geometry, but also a change in mechanics. And as I said, we wanted to separate the two. So in order to do that, we used FE-Bio, as I mentioned, and we tried to answer these questions like why we want to use computational. That's because sometimes the phantoms of the experimental work can be time consuming, and there's definitely different material geometry implementations. We used FSI, fluid solid interaction, instead of instead of CFD, computational fluid dynamics, because we wanted to look at the possible propagation, which is a fluid structure coupled phenomenon. And then, of course, the geometry is very complex, so there are too many independent parameters, and we wanted to see whether we can validate for the first time by using fluid-solid interaction. So the way we did that was actually also validated with experiments. We had to make polyvinyl acrylamide phantoms and match their finite element models, and then compare the two, make sure that the simulations are informing the phantoms, and understanding both that the idealized model is actually something more realistic. So we went back and forth. We used actually what we have as an inlet in from the pump, that we have a peristaltic pump that we use for the phantom. We use exactly the same inlet curve, pressure curve for the fluid-solid interaction. And then we look at the outlet pressure with having the geometry very similar to what we had in the phantoms. So this is how we mapped it. We had 85,000 quadratic elements, tetrahedral, hexahedral, and pentahedral. We had actually the plaque here that was changing, either with causing a 50% or 70% stenosis. And as I said, that was very similar to what we had also in phantoms. We also had the properties of a gelatin surrounding medium that was a compressible neo-Hookean viscoelastic solid, and the blood mimicking fluid, which was a viscous Newtonian fluid. So when we entered all that and we ran the simulation, we're able to see the wave propagation on the wall, but also the actual change in the fluid. And we could see that during the propagation, there was a disturbance of the flow as a result of the plaque. This is a 50% stenosis, and the flow was very different before the plaque and after the plaque. And then, of course, with the 70% stenosis, that was even more accentuated with the vortex building at the post-stenotically, and looking at the also a much larger disturbance here, causing also reflection. So then we compared with what we had in the phantoms, and I'm showing you that here we had the 50% stenosis on the top, 70% stenosis on the bottom, and we can see on the left the coupled to vector Doppler on top of the pulse-wave velocity, pulse-wave imaging, and then we did also this particle velocimetry, where you can see how it changes from 50% to 70% with a large disturbance, similar to what we saw also in this simulations. And then we saw a very nice correlation between the phantom pressure and the fluid solid interaction pressure that we measured, and the same was also true for the spatial temporal plots between the phantoms on the top and the simulations at the bottom, especially with a forward wave in red and subsequent reflection waves in blue here, and overall very analogous pulse-wave velocities in both the phantoms and the fluid-solid interaction. And as I said, before stenosis and after stenosis, different curves, but overall, including at stenosis, very good correlation between simulations and experiments. So that allowed us to validate our simulations, and we're continuing that now with animal models that I don't have time to share with you today, to be able to validate some of that and go back and forth and see how much of the geometry is affecting our measurements versus the mechanical properties. So the last thing I want to share is a method, is a technique before I go to the clinical findings, is the wall shear stress imaging that I mentioned, that is almost like something that that physiologists have always wanted to know. What is the actual wall shear stress in vivo, and how does this enter the equation when it comes to anything from formation of disease to progression of disease to causation? So this goes way back. So wall shear stress is the frictional force that's generated by the blood flow, and is a key parameter, and has been linked to atherosclerosis through a couple of ways. One is that high and unidirectional wall shear stress aligns the endothelial cells, and then a low and oscillatory washer stress contributes to plaque formation. So we wanted to image that by combining our methods of color Doppler and spectral Doppler, and then develop that together with what we have with the pulse wave imaging and the washer stress. So the way we do that is that we do segment the vessel wall, and then we have an angle of the flow velocity vector in the x-axis, an angle of the tangent of the plaque with the x-axis as well. And of course, we take advantage of the component of the flow velocity that's measured at the wall tangent. And then the washer stress is simply the actual measurement times the average of the velocities and in those directions. So we were able first to use phantoms and the simulated washer stress, and we're able to confirm the washer stress measured, and we can map it very similar to what we have with the compliance. We can map it across the entire wall. We can see, for example, that at the stenosis, we get the highest washer stress, 4 times higher. And also the distal wall as well, even if it doesn't have a stenosis, it has the similar washer stress. So very nice correlation between the phantoms and the simulations. And then we did also the 70% stenosis, and we found that we can have even higher washer stress as a result of this higher flow velocities higher than what we have in the 50% stenosis. So the washer stress increases with the stenosis level, and we found that we can correlate that between phantoms and simulations. Okay, so for the remainder of the time, I want to show you what we have found now while we image humans, and we try to understand further the progression of atherosclerosis. So we have done both healthy subject scans, as I already shared earlier, but I'm going to share some more first before I get to the patient scans that we look at before and after the endarterectomy. And then when we have an endarterectomy, when we actually get the plaque sample, we can correlate some of the constituency of the plaque to what we find in vivo. So first, the human carotid, it has a very nice forward wave. Then you get some reflections that you see here at the bifurcation that I'm not showing. But overall, you can have the propagation of the wave and also see the distension by eye through the actual overlaying of to standard conventional ultrasound images of the carotid. And most importantly, with our technique, we can measure the compliance. This is a 4 subjects, normal subjects, and we can measure overall very similar compliance in the subjects. And we can see also some softening of the carotid as we get closer to the bifurcation. That has been reported by others, but we can actually map that. So our carotid is not necessarily completely uniform. It actually varies even in normal vessels, especially close to the bifurcation. So we have found that when we measure that, we get very similar measurements between the regional pulsewave velocity and the piecewise velocity. Overall, very nice correlation above cardiac cycles, and the compliance also is within the standards that have been reported by others for the compliance. So after verifying the compliance is accurate in normal subjects, now we can actually see what happens in a much more complex case where we have propagation. Now very similar to what we did in FSI simulations, but also in phantoms, but now of course in a much more complex structure and system. So we can see that we have a wave now propagating through a plaque on the top that has a very non-uniform propagation that also informs the distal wall. And then when we image that, in this case, we can see that the compliance is definitely not uniform in this case. In fact, at the actual plaque, we can see the compliance has, in this particular case, a decrease. And then we have a very soft region right before at the shoulder, as it's called, of this plaque. So when this patient underwent carotid endarterectomy, CEA, and we were able to get hold of this plaque sample. And then we saw that in the longitudinal section, we were able to match the overall geometry and identify the plaque itself that had a necrotic core, informing potentially some of the compliance decrease. This particular, looking at this particular case a little bit more closely, we can see that the axial wall velocities and the compliance maps match. So in the case of increased axial wall velocity, we get decreased compliance. And then in high compliance and increased axial wall velocity, and in decreased axial wall velocity, such as in the case of the plaque, we get low compliance. And that also has the shoulder, the change in the shoulder instead of the plaque has been actually identified as a common site of rupture, and I'll show you another case later on. So 60% of the time, this is the region that gets ruptured, and we have identified that as a potential in this patient as a very high compliance, and therefore a potential flexible area for rupture. When we look at different types of histology from H&E and Mason's trichrome that allows us to see the collagen and potential damage in the vessel, we were able to identify classification and increase collagen content where that very nicely correlated with the decreased compliance. So we also looked at endarterectomy patients after they received the endarterectomy. So I mentioned earlier that we can get the plaque sample and look at that and correlate that. Now we can see whether after endarterectomy, the actual vessel was able to get back to normal. And we were overall seeing that before and after endarterectomy, so after removal of this plaque, where there was a pulse wave velocity that was not uniform and was actually overall slightly low, but also the correlation was dropping, we were able to get a more uniform velocity, higher, and also a very nice correlation coefficient. And when we look at that in a few patients, and before and after, there was a completely different picture, literally, of what was happening both with the pulse wave velocity, but also with the compliance. In fact, in this particular case, it went from very high compliance, which is also correlated with vulnerable plaques, to very high compliance. Sorry, to low compliance. And that was indeed a vulnerable plaque, which is in pathology identified as ulcerations and necrotic core, as you can see here. So when we look at a few different subjects, we're able to see that before and after endarterectomy, overall the pulse wave velocity was coming back, and the coefficient of variation as well as the correlation coefficient was coming back to normal compared to before endarterectomy. So then the homogeneity also is actually another marker that we were looking at, how homogeneous is the actual plaque, and allows us to identify regions. For example, a normal carotid will have only one region. Here we see 3 different segments that are identified by looking at the variation of the pulse wave velocity and identifying in this particular case as the nodic segment. And then overall we would see that healthy carotids typically had one very similar compliance. The stenotic segment typically had, especially calcified, was dropping in compliance and then increasing again in non-calcified. And overall, the number of segments that were inhomogeneous were about 1 for healthy and much higher than 3 for atherosclerotic carotids. So overall, this could be another biomarker, the inhomogeneity of the vessel. So for stroke volume, we were able to see no significance, but we could see that the peak flow velocity definitely changed from low stenosis without stroke to dropping for patients that had actually suffered stroke. And then controls seem to be actually different from low stenosis with stroke, but not significant difference from low stenosis without stroke. So definitely a difference in peak flow velocity for stroke patients. We're also looking at the standard deviation of the angles in the flow. So the flow was more turbulent in patients with a history of stroke compared to the other patients with low stenosis and normal controls. And then we could also see additional biomarkers that the wall shear stress was actually increased in controls compared to low stenosis and stroke. So we could actually see something that we also had consistent with the PEAK study, that arteries with low wall shear stress developed atherosclerotic plaques later on. So wall shear stress could potentially be a biomarker for informing plaque formation. And then we will put post-wave velocity and compliance together. We could see that the stiffer carotid arteries had been highlighted with as a risk factor for stroke, and the lower stiffness was indicated in our PIC study and mouse study as indicative of atherosclerotic progression models. So we had also correlations with other imaging techniques such as CTs, and you can see here a CT scan of a very calcified plaque of 70% carotid stenosis that shows up as this blooming artifact of very high intensity in CT. And then we matched that with our wall shear stress imaging and our adaptive pulse wave imaging, identified these three areas of inhomogeneity. And the plaque composition in another patient was also confirmed also with CT in a non-calcified plaque here that had high wall shear stress at the plaque location, and also identifying this relatively low compliance plaque, but also higher compliance plaque in three different areas. We compared also additional CT scans in a few subjects, and we were able to see a nice correlation between wall shear stress and the area of the calcification. And then we also had this particular case that I showed you earlier. That was an asymptomatic patient, and another case of a symptomatic patient that we found with a necrotic core in an area of a very highly compliant plaque. They turned out to be vulnerable. This is actually another case where this site of the shoulder of the plaque had ruptured as a result of a high wall shear stress that we were able to image, and confirming that potentially high wall shear stress could lead to rupture. Another patient we confirmed with histology that had extensive calcification, and we were able to see low compliance. And then another patient that was symptomatic in this case, also low compliance, that was confirmed with necrotic core. So overall, we were able to correlate compliance with non-calcified versus calcified. So non-calcified plaque had higher compliance overall than calcified plaques. Age-matched controls had significantly different compliance than non-calcified, but not from calcified plaques. And calcified plaques are known to be much more stable than non-calcified or high lipid plaques. Pulse wave velocity actually offered a significance between calcified and non-calcified plaques, but also a significance between calcified plaques and age-matched controls. So overall, we saw a significant difference in pulse wave velocity that we couldn't see in the compliance, potentially saying that the actual structure is also important as opposed to just the mechanical properties here. And the final thing I want to share with you is that the wall shear stress is something that we can measure for plaque development. We're looking at matching here the different sites in a porcine model. We were able to identify regions of high wall shear stress with the plaque formation, and identify also sites of compliance where we had ligated in one of the carotids in the actual porcine artery. But overall, in And what we have done in patients is that we've seen that the peak washer stress is actually correlates nicely with no plaques. And then as soon as a severe stenosis or even moderate stenosis occurs, it actually correlates with low washer stress. And in fact, we can see almost that in moderate stenosis, the washer stress is higher than severe stenosis. And then we also looked at oscillatory stress that has been linked to vulnerable plaques, and we see that it is definitely higher in stenosis than in non-stenotic vessels. So overall, in conclusion, I hope to have shown you that pulse wave imaging is a versatile technique, ultrasound-based, that can map the arterial pulse wave propagation and wall pulse wave velocity, propagation uniformity, and compliance. We can do this in 4D. We have integrated flow. We have validating fluid-solid interaction models, and we can perform also washer stress imaging. And this has allowed us to look at atherosclerotic plaques from the point of view of how lipid and calcified plaques can be differentiated, assessment of interventions such as endarterectomy, and overall look at the additional biomarkers for informing plaque stability. We're currently looking at linking compliance to plaque constituents, so continuing that. Structural versus functional parameters, so separating geometry from the actual velocities in simulations, and then wall and plaque shear stress in patients, continuing that, and then to inform early onset of disease and the potential prevention of stroke. I want to thank all the team members and collaborators that have contributed to this work, the NIH for funding, my group here that's doing all this great work that I mentioned, and I want to thank you for your attention. Thank you.